We're going to move on to our next guest, Eric Habericher. And Eric, welcome to the show.
Oh, thank you. Glad to be here.
All right, I'm glad you're here too. All right, you're the Director of Marketing for Access Healthnet. Eric, give our audience a feel for who you are, what you've been doing in the industry sector, and then talk us through the processes of the emergence of value-driven retail healthcare.
Sure. Yeah, I'll just start with, I'm actually the founder, chairman of the board, and CEO of Access Healthnet.
Oh.
But minor correction there. So this whole kind of move to value-based care, has really it's been out there for a long time, but it's been kind of in its infancy. I started in this space about 12 years ago by opening a quality assured flat rate imaging product. And what we've seen is kind of that idea of value-driven care and direct contracting between providers and self-funded employers, growing, very slowly up until quite recently. And I think probably the single largest accelerator in this space has been when, Amazon, Berkshire Hathaway, and JP Morgan Chase, took a shot across the entire healthcare industry's bow and said, what we want is, a fundamental change. We want transparency. We want value-driven care. And we want, a lot of, when I say transparency, I don't just mean price transparency, but transparency to the entire process. If I'm self-funded and I'm paying a $100,000 claim, I want to see line item detail. I want to know exactly what I'm buying, and I want to know whether or not that claim was adjudicated properly. If I'm working with a pharmacy benefits manager or a PBM, I want to know what markup they're taking, what discounts I'm getting. I want to know, if there are rebates from the manufacturers, what percentage of that am I getting, or are they keeping it? And that's really what's being demanded. And as employers become more aware of how much hidden money there is in the healthcare world, almost 50 cents on the dollar is absorbed by this kind of invisible paper economy of repricing and debt collection and hidden holdbacks and incentives that are paid within the industry that no one sees. As employers are starting to see that onion unpeel and find out that it's kind of this ugly, rotten thing on the inside, they're saying they want a better way, a more direct transactional way, and that's what we're doing, is creating a single point of connection between providers that are offering value and employers or plans that want to buy value.
Talk to me about the bundles, how they're different from traditional payment methods.
Yeah, so there's, the prevailing payment methodology that's out there is something called fee-for-service, right? And fee-for-service is kind of like piecework in a factory. I have two employees. One guy's making 100 parts an hour. The other one's making 150 parts per hour. The guy making 150 parts per hour gets paid more. And what that's done in the healthcare world is it's created a kind of a adversarial relationship that isn't necessary between the payer and the provider. So the payers are now saying, look, we want to pay less. So we're going to deny more and more of the piecework work that you do. And the providers are saying, well, if you're going to deny a percentage of it, then we have to charge even more of it, because they can't just keep raising their prices. So there's this incessant war between providers coding for revenue and payers denying charges. And the folks that deny the charges keep a large chunk of the money for the charges they deny. And this is the major cause of this loss of value. So when a bundle, it works completely differently. What we're doing is we're defining an episode of care, something like a knee replacement surgery as an example, and we're standardizing the provision of that care and the shared risk the provider has to take, so that every provider we work with that's offering that procedure is offering the same procedure, the same components of the procedure, and taking the same risk in offering that procedure. They're doing so and guaranteeing both a price and an outcome. It's not the real number, but let's say it's $25,000 for the knee replacement instead of the $24,000 to $75,000 the employer is paying right now. They get a guaranteed price, and if that patient will require additional work because of an infection or a complication, the provider is sharing in the risk and agreeing to make things right on their dime.
What about the savings? I mean, you mentioned that there's a price differentiation. I know transparency, the bundling work with this, but give our audience a feel for the type of savings your approach brings versus a traditional approach.
So what we've been able to do over the last couple of years with our clients is save them anywhere from 7 to about 20% of their total medical spend. So if you're spending $11,500 per employee, which is the national average, you're saving maybe $800 to $1,300 per employee by utilizing our program, and that's a global savings off their total spend. Now we don't offer everything. We focus on therapeutics, diagnostics, and surgery that is non-emergent. But we're getting into places like behavioral health and oncology and cardiology is emerging from our product right now, as well as the delivery of some of these very expensive recurring biologic medications that you have infused at a hospital, which can make up a giant percentage of the spend. So if you look at individual episodes of care, like that knee replacement surgery, typically you're saving anywhere from, say, 15 to 75% over what you would pay under the current PPO contract. Now, the savings is impacted by the fact that our program requires that the employer share the savings with the employee by not having them pay out-of-pocket amounts. So if you would look at, that knee surgery and somebody with a $5,000 deductible, the employee saving $5,000 that's staying in their pocket and making their health plan much more valuable to them, and the employer is passing again some of that savings on. Well, they used to pay $40,000, now they're paying $25,000. They're waiving $5,000. They have a net cost of $30,000. They still save $10,000. It's pretty easy math for the employer to want to do that.
All right, we're going to need to take a break. Eric, on the other side when we come back, I want to talk about the providers, why they're electing to work with you versus what they've been doing in the past, all right?
Sounds good.
We'll be right back with Eric Habericher, co-founder, CEO, Access Healthnet, accesshealthnet.com. And the segment has been brought to you by Tycon Partners. You've been listening to CEO Money with Michael Yorba. We'll be right back. Welcome back to CEO Money. I'm Michael Yorba, your host. I'm speaking with Eric Habericher, CEO, co-founder of Access Healthnet. All right, Eric, where we left off when we last spoke, we were talking about the savings that you're bringing to the world with your processes that you're implementing in an industry that's wrought with all kinds of negative things that I don't even want to get into for my own personal reasons. But you have got to deal with the providers and give them a value-driven statement to work with you. That's not an easy wall to climb. How have you been able to overcome that and get these people to work with you?
Yeah, I think it starts with the idea that that's the side of the world that I came from. I spent the first 17 years of my medical career, working at a major health system here. And frankly, I was very proud of the work that we did. I wasn't necessarily proud of how we monetized, and that's what made me leave the hospital world and become an entrepreneur. But I really understand kind of the rock and the hard place that a lot of providers are put between. So there's 3 messages that I bring to the provider space that allows them to see why working in this manner is going to really be better for everybody. And, you kind of walk in there with them thinking, oh, here this guy comes to, kind of beat us up, and we leave with the white hat. So the first thing that we have to understand is that if you look at the medical inflation that we've experienced over the last 50 years, provider charges really aren't the cause. If you look at physician and other professional reimbursement, it's been virtually flat versus inflation. The facility fees are up a little bit. Novel treatments are up. Pharma is way up. But the majority of the inflation has been the cost of administering the plan of the claims, all of that kind of hidden economy, paper economy that I talked about. So providers understand that just to a certain extent. But they don't realize that in many cases, the folks who are repricing a claim that they submit are making more than the surgeon. In fact, egregiously more than the surgeon for pushing paper. So when we're able to go to the providers and tell them that we can help them to create a direct channel between themselves and the employer community in their market and in a greater market as well. That's actually happy news, because you really have two parties here. You have providers, they want to sell, and you have self-funded entities, employers, they want to buy. If the provider is willing to offer in our free market solution a great price, the payer is, the employer, they're willing to buy it, and they're willing to pay them in a timely fashion and in full. And the reason that they're able to pay them timely and in full is because, again, they're creating that shared savings with the employee. So from the provider's perspective, instead of going out and chasing, an employee who may have as much as a $10,000 deductible, making 40, 50, 60 grand a year, that's bad debt. They're just not going to be able to collect that. Now they replace that with getting paid in full in 21 days or less. So it's completely non-adversarial, it's free market, and we actually show them with some very simple math how they can get paid more by charging less. The super simple highline math is that the national best practices standard is that a provider will collect about 63 cents on the billed allowed dollar. So when you get your EOB from the insurance company and it says that you owe the provider $100 via insurance and your out-of-pocket amounts, the average is that they'll collect 63 cents. So in our model, where they get paid a dollar for a dollar, they could, instead of charging a dollar and getting paid 63 cents, they could charge 75 cents and get 12 cents more. It's pretty simple math, and that's exactly why providers, love what we do. And then again, and also the fact that it's not adversarial. We're not negotiating. We're telling them, this is the bundle. Give us your best price, and we'll go out and market it to the employers for you.
Okay, that's a big differentiator. What is there any other initiatives that you work with that make you better and different?
Well, I think the other thing is how we bundle. So there really are kind of three versions of bundling. The most common kind is what Medicare does, DRGs, and now they have some new bundles for episodes of care. They're very long. They're not crazily well defined. And providers, quite frankly, it's kind of a take it or leave it. It's the government. If you want to participate in Medicare, this is how we pay. You don't want to participate in Medicare, you don't. And it's been kind of shoved down their throat. And I'm not going to say that providers love DRGs, because most of them don't. Having been one, I can tell you we didn't like them. The other kind of bundling is this kind of retrospective bundling. And this is, Mr. Provider, go do things the way you always did, and then we're going to suck out the part of the bill we want to pay and call it a bundle. That's really no different than retroactive claims denial. And most of the people who are retro bundling are also based on a shared savings model, where if they, knock off $100 from the claim, $33 goes in their pocket. Now, we don't do either of those things. So all of our bundling is prospective. We've standardized the bundles nationally. The providers know exactly what services they're going to be required to cover, what the risk they're going to need to assume is, and then they give us a price that's sustainable for them. And it's not a race to the bottom. It's a natural evolution to the sweet spot between sustained profitability for high-quality providers and value for employers.
Eric, we've got about a minute, a little bit less left. The super option and who can best benefit from it?
Any self-funded employer. I strongly encourage you to check out our website and then talk to your broker and ask them how you can get involved and bring this to your employees. We also have a product called the Super Option Direct, which we've just launched, which we're putting into the hands of direct primary care doctors across the country and a number of medical share programs, these health share programs. So again, we're expanding that value to as many people as we can. There's a lot of consumers out there who need help and who need to, achieve that 30, 40, 50% discount that we can.
That is a great note to end on. Eric, thanks for being a guest on the show.
Thank you very much. I enjoyed it a whole lot.
Me too. Eric Habericher, co-founder, CEO, Access Healthnet, accesshealthnet.com. And this segment is brought to you, again, by Tycon Partners. You can listen to CEO Money with Michael Yorba.